welcome Dr. David Chang and request him to give his presidential lecture.
Well, thank you for that lovely introduction. It's such a pleasure to be here. So I'm going to be talking about frugal innovation. This is not advancing, there it goes. So I am a consultant for Foresight Robotics. We recently celebrated 50 years of ASCRS, and if you think about all the things that have happened in all of our inter-segment specialties during that time, it's been an explosion of innovation. Much of this is expensive technology. So I'd like to shift our focus today to frugal innovation. There's a Hindi term used a lot in engineering called jugaad, and that's to be innovative and unconventional to get solutions with limited resources. But this is now going outside of engineering, being more frequently applied to healthcare. And what does that mean? Well, we have to still be efficacious, but can we do it more affordably so it can be more accessible and therefore also sustainable by not wasting resources? It can apply to interventions, devices, or services. So imagine, for the last 30 years, the way we did cataract surgery was we used the machine to do the capsulotomy, and then someone figured out that with a reusable 25-gauge needle, you could manually get the same result. Well, that's what jugaad would be. So more than 20 years ago, I made the case that our greatest challenge in cataract surgery was the growing backlog of global blindness in low to middle income countries. And obviously that's because the great burden of blindness was concentrated in countries where the number of ophthalmologists was least. But I think that today, the same access problem is going to affect higher income countries because of increased demand with our aging populations. Refractive lens exchange is going to mean we need much more in the way of cataract surgeons, and yet we're going to have insufficient manpower, and we have to do something to make sure that this exploding volume is somehow sustainable. For this issue on planetary health by the Royal College of Surgeons, we wrote that we need to look at frugal innovation. And we use the example of the Aravind Eye Care system, known to this audience very well, as an example of how to do that, how low resource settings can teach us to be more efficient and to be more sustainable. So out of these 14 hospitals, they now do 450,000 cases a year. My first trip there was in 2003, and I've just been so blessed to have friends and colleagues there to collaborate now on almost 24 papers over the years, trying to teach these lessons of how to do better with fewer resources to largely the West and the rest of the world. So I'm going to highlight 5 examples of frugal innovation that they've pioneered, starting with manual small incision, a square edge PMMA lens, intraocular MOXIE, and also the reuse safely of surgical supplies and devices. Well, you all know that manual small incision is a tremendous procedure for these advanced cataracts in which you can still end up with a small incision and control astigmatism without the need for an expensive phaco machine. Dr. Harapriya and I did one of the first large studies to look at the safety of this compared to phaco at Aravind, 80,000 during 1 year at Madurai, equal complication rates for experienced surgeons, but inexperienced surgeons had much higher complication rates with phaco, making the case that for the very advanced cases, we should be looking at M6, particularly with those surgeons who are not phaco masters. Of course, they've also pioneered the high-volume surgery model, the so-called Aravind model, using one surgeon with 2 OR tables, assembly line, emulating a fast food in terms of delivery and efficiency, and then having cost recovery where you provide the highest private care to subsidize care for the charitable cases. Now, they are able to reuse all of these things that I've listed that we're prohibited from reusing in the West, enables them to provide almost 60% of their surgery at low cost, and this again is the 23-24 year volume. One of the projects we worked on was to put a square edge on the PMMA lens. I pointed out the classic Nishi experiments where he showed that you could actually put a square edge PMMA in a bilateral rabbit eye that was just as good as the expensive American foldable lens and stop PCO, which, you know, is an inconvenience in my country, but a big cause of visual disability in low-income countries. And the cost of doing this was just $1. It's on every Irvin PMMA lens now. This is Dr. Haripriya's study, bilateral eyes with PMA round edge in red, and you can see that if you follow far enough out, it just keeps going up, whereas the square edge in the other eye in blue, it pretty much halted PCO for $1. Another collaboration was intraocular moxifloxacin. This required Oramax to get approved Moxi in India for the cost of $1. Using it on multiple patients, 6 patients, it's basically 15 US cents. This is our first study looking at M6 patients at Madurai, large numbers, cutting the rate from 30 to 6, and then based on that, moving it to the system-wide to the point where we were able to present on 1 million consecutive without and 1 million consecutive with intracameral moxifloxacin with a very significant reduction in endophthalmitis, down to 1 per 10,000 when you just looked at phaco. And again, a cost of $1 and enough then for 5 patients from that vial. Surgical devices and supply reuse, and this really gets at our problem that we're going to all face, which is access due to sustainability. I practice efficiently as the rules will allow me in the United States. It's still amazing how much trash we generated. We should be aware that the WHO has declared that climate change is the greatest health threat facing humanity, with the burden of this disease and morbidity, mortality borne by the poorest societies and countries. Eye care will be no exception. The IAPB has identified a number of diseases, blinding, disabling, that are going to increase with that. And the sad irony is that we, the healthcare sector, are such a big contributor to the climate crisis. If we were a country, we'd rank number 5 in terms of annual global admissions. My country is one of the worst. Look at the percent, it's increasing. Most of this, manufacture, use, and disposal of supplies. And within medicine, of course, ophthalmology, we have these in ridiculously high volumes, including cataract intravitreal injections. So these are the things that are routinely reused at Irvin, and as a result, the carbon footprint of one phaco at Irvin is equivalent to driving an automobile 25 kilometers. It's 20 times that when you compare one phaco at the UK. Most of that difference is single-use supplies and drugs that account for a lot of that wastage and increase in the West. So if you consider that all of the cases have these items reused and how everything else is standardized, we actually have a really good model. So I went back and looked at those 2 million cases as an aggregate. That's what happens when you reuse everything. On 2 million cases, you get an infection rate of 4 per 10,000. Half of those did not have intracameral moxi. So how much better are we in the United States, where we are required to throw everything out after one time so that we can be safer? Well, we get the same rate. This is from the IRIS registry, 8.5 million cases during an overlapping period. Huge data. And so this is really disappointing. I mean, we're spending and wasting 20 times as much, and we're not getting any benefit for it. That's really infuriating, but it's also very encouraging. It gives us reason for hope. It tells us we could really cut down on our waste and our cost without harming patients. So how controversial an idea is this to reuse all this stuff? Cassie Teal and I wrote a survey, and we conducted it first in North America. We repeated it in ESCRS, And there's a survey now going around for the APAO societies, and we're collecting data there as well. And what we're finding is a strong consensus, surprisingly strong, that people are concerned about global warming, excessive trash, want to be able to reuse things more often, want discretion from manufacturers and the regulatory agencies to be able to reuse things. And we have data now on willingness to reuse topical, intraocular drugs and supply items on multiple patients. It's very broad. Well, tackling this is not going to be easy. It turns out there's not a lot of evidence against this. This is all based on expert opinion, and that gives it a strong bias. It's eminence rather than evidence-based in terms of why we have to throw things out. And some of it is just general surgery recommendations that we follow by default if we lack our own. A classic example was when our government wanted to end short cycle sterilization. And we, Nick Mamelis and I, led the task force that wrote our own guidelines to validate and defend the ability to do this short cycle, what used to be called flash sterilization. In order to reuse something in the United States, the manufacturer has to validate the FDA that it's safe to reuse that. And this is expensive, and basically with the throw in profit liability, there's absolutely no incentive for manufacturers to do this. But the problem is, if they don't validate it, it gets classified as single use by default. So we took, and this was done at Utah, a single-use phaco-tip and validated that there's no problem with reusing it 20 times, but the manufacturers just aren't going to do that. What about the cross-contamination? You have all these patients in the same room. This is a study we did at Aravind after COVID, where to reopen with the threat of COVID transmission, all of the strategies on the right were adopted by Aravind temporarily for COVID. And if you go and look at the endophthalmitis rate, it didn't change. So all these things, if we force them to do the things on the right, would make no difference in safety, and yet they're treated as the gospel in the US. In terms of reusing things, this is another study that we did, and we cultured all of these items that are either reused, flash sterilized, huge number of cultures, not a single one was positive. So in terms of whether reuse is safe, we have expert opinion. I showed you big data, environmental study, and now microbiology that says that we just cannot find the danger in reusing these things. And basically that's what Aravind had figured out. So just look at what they're able to do with these high volumes. These are the innovations, but look at how frugal they are, and I can't think of a better example of that. Now, what about access? Because that's going to be the problem in my country as well. In terms of sustainability, we have formed a coalition called iSustain. These are the sponsoring societies here, each of which has its own committee. We now have 53 global member societies. If you look on the roster on our website, it includes AIOS and APAO. This is where we can share news and journals. We have 7 things that everyone's facility can do right now to lower your environmental waste carbon footprint. This is where we put our position papers. We have 3 with more to come. And we work with industry. Industry is a big part in terms of the solution. There's no reason we need a paper instruction with every single product, so we have a position paper against that. We have one phaco machine in the United States with reusable tubing. So when we switched to that, it meant that I have one cassette that replaces 20 of these plastic cassettes in packages. But we have lobbied hard for industry to develop and innovate a cassette you leave in place all day, which is what so many people are doing around the world anyway. Charge a click fee so you make your revenue, but don't make us throw it out. DropMate is, Vikram Shankar was a resident at Stanford, and he came up with this technology to safely disinfect without chemicals bottle tops, tonometers, gonio lenses, because believe it or not, many U.S. institutions require these to be single use, to be thrown out because of the threat of infection. And so this low-cost unit, which he got through the FDA, is able to obviously generate tons of savings for those different settings. So this is our challenge with our, I'll need a little more time, with our challenge is really to take this opportunity and obligation to do more. Let me just say something about the increased demand and our manpower problem. We've known for years that, at least in high-income countries, we have more ophthalmologists per population. That's why we don't have the burden of blindness. But as I said earlier, we're going to be in trouble in terms of manpower, and we're going to not meet the needs. So you may have heard a little bit about robotic cataract surgery. I'm the Medical Advisory Board Chair for Foresight Robotics. And what I'm doing here is surgery on an animal eye, but the animal eye is in another room. And I am controlling robotic arms using a 3D heads-up display, and everything is being done, this complete cataract surgery, on the eye in another room. So this is an amazing advance that this even exists. The hardware is there to do the entire procedure, and you can set it up so the workstation, you don't even have to be sterile, as you see here. Now you're going to say, well, how is this frugal if you found a really expensive way to do something that we already do really well? And the way this could be frugal is if you then brought it to become a fully autonomous system. And how would this happen? Well, this is the Stanford Autonomous Helicopter Project. They used machine learning to learn from this 20-year experienced helicopter operator. These are large models that are doing aerial stunts. And this is actually the computer software flying it based on learning from someone else doing the same controls earlier. And they have to account for different wind and temperature and lift and humidity. And these are really complicated maneuvers that, again, it took this other person, he's got 20 years of experience to do. So the software is there that can do this. And if you can then train that robot to do a routine cataract, or RLE, it would allow me or any of you to sort of oversee multiple surgeries done at the same time. We would do the more difficult eyes. And because software and hardware can be infinitely scaled, you could really democratize access with consistent quality for far less than it would cost to train and compensate an entire extra generation of surgeons. So my conclusion would be to appeal to all of us in our profession to think not only in terms of more expensive ways to do this, but to also think frugally and how what we do can sustainably help the most people. Thank you very much.
David, I'm going to ask a very rude question to you. How old are you?
Well, I turned 70 last year, so hopefully I can keep doing this for a little bit. Yeah, 70.
If David is 70, I think I am 90 at least. Because the way he has thought, the way he has delivered this lecture, the way he has given a vista right from the frugality of ophthalmology to what we do unnecessarily to where we can go to a necessity is phenomenal. I think we should give David a standing ovation for this.